Right. I have to make an apology at the start of this to Mr. Smith, to Austin Smith, because I didn't know he was going to be here. And you'll see in a moment, Austin. Right. There we are. Quite a nice picture there. That's because you messed with my slide. Because the one with the names wasn't supposed to come up until all those had come up. But never mind. And of course there are thousands of minor salivary glands. Okay, parotid, submandibular, sublingual, the main ones that we talk about. So most salivary gland lumps are benign tumours. True or false? Correct. Salivary gland stones and calculi are common. True or false? Ooh. That wasn't a that was a ooh. Salivary gland lesions occur more frequently in the submental glands than the parotids. True or false? That's correct. It's false. Okay. So that's again a little summary. Most lesions in the parotid glands are benign, but most lesions in the submental glands are malignant. True or false? Close one. So, as a quick rule of thumb, for parotid, 80% are benign, 20% malignant. Oh, that's not very good maths. Is that you?
It was
Cut and paste.
I think it was at 2:30 in the morning, but I think it was still you, Mr. Wickham. I don't know.
How did you know I was up at 2:30 in the morning? So submandibular is about 50-50, sublingual 20-80. So common causes of unilateral enlargement of the parotid. These are well known to you, I'm sure. We're seeing actually, and Austin I'm sure will agree with this, a lot of an increasing number of parotids with lymph nodes in that are metastatic nodes from skin squamous cell carcinomas of the scalp. So we seem to see a lot more than that now, of that now. Now, whether that's because in the past we didn't get to see it, and because things have changed, we now do get to see it because guidelines have changed, and we've encouraged people, well, dermatology, I suppose, especially, to refer patients who've got lumps in the neck to us because they may need a neck dissection.
Can you please elaborate a little bit on stones and calculi, because that's something in general practice we tend to see, sudden enlargement of parotid glands, etc.
Yeah, well, obviously the main thing is unilateral sudden enlargement, usually of the parotid or the submandibular, and classically associated with eating and drinking, or even sometimes smelling something nice that makes you salivate. That will result in the gland swelling, being uncomfortable or even painful, and classically over a period of a few hours the swelling and pain will subside as the saliva sort of creeps past the stone in the duct, and that can be repeated at intervals until obviously the patient thinks, I've had enough of this, and they come and see you. Sometimes you can palpate, particularly for the submandibular salivary gland, you can palpate a stone along the duct in the floor of the mouth. sometimes when the patients come to us, we can actually take that out under local in the clinic by just making a little incision over it and popping it out. I did that a little while back. Got out a stone of probably about 1 centimetre long. Very nice. Gave it to the patient. A few days later he came back. He said, I think I've got another one. And in fact he did indeed have one, same sort of size. I took that out, and when you put them together, they had a lovely sort of facet joint between them.
Do we need to investigate in primary care somebody with that kind of symptoms, and when should we refer?
I think if you've got a classic history of eating and drinking bringing on swelling, which then subsides over a period of time, then is repeated, and I think it's perfectly reasonable to investigate that in primary care. One of the problems is that when we want to investigate it and we discuss it with our radiologists, one week they suggest a certain type of imaging, and then the next week they suggest something else. And electronically it's quite difficult to request, could you try that or could you try that, if you see what I mean. So, whereas before we would say, right, we want a silogram, or, contrast silogram, and they'd squirt some dye in and all that kind of stuff. Now sometimes they might use MRI, they might not, so it is a little bit difficult. But I think in general it's worth investigating in primary care, because if you come up, if you go on ICE, it will say there will be somewhere that says silogram. So okay, in that case I don't think it's a very good idea.
Ultrasound
could have saved me all that.
I'm not as clever as Dr. Smith yet. So ultrasounds are no use?
No, I wouldn't say they're no use, but they potentially can isolate a calculus, yeah. So ultrasound maybe for yourselves might be the investigation of first choice, yeah.
And antibiotics for parotitis? That's something else we see in general practice.
Well, I think it depends what you think the cause of the parotitis is. If you think it's bacterial in somebody who's dehydrated and sort of frail and so on and so forth, then that's probably bacterial, so yes, antibiotics. But a lot of the time it's viral, so antibiotics, unless you've got a secondary infection, not really appropriate, I wouldn't have thought. Although I know we do see patients that you've seen who say, Doctor gave me antibiotics, it was fantastic, swelling went down. Lucky. Oh yes, submandibular gland. Yeah, it is actually, in most people you can palpate the submandibular gland quite easily, and to have a little bit of variation between the two sides is not uncommon. But obviously it's a consistency thing as well, so if one's feeling very firm and significantly bigger, then it definitely needs investigating. No question about that. So it's just slightly repetitive, that, and that's reasonably obvious. Oh, now then. I think that must have been at 2:30 in the morning as well. Just got the wrong font size. This is really specific to Barnsley, obviously. This is another controversial bit, Austin. Which is true, though.
Yeah, it is true.
So yeah, typical ENT clinic scenario: 60 plus, lump in one parotid, ultrasound scan, ultrasound guided fine needle aspiration, probable pleomorphic adenoma, query Wharton cyst. We do a partial parotidectomy. You may hear, may hear the term superficial parotidectomy. I tend to use the term partial parotidectomy because, to me, superficial parotidectomy implies that we take out all of the superficial parotid, which we don't necessarily have to do. And then histology shows pleomorphic adenoma in about 80%. Don't ask. Why do we do all these parotidectomies? We don't actually do very many, to be honest. Okay. Any questions?